Hi, y'all. This is Joanne Eason with Five Wishes, and we're doing another one of our Instagram Live conversations with some of our friends and influencers on Instagram. And I'm excited today to introduce Dr. Matthew Tyler. He is one of Instagram's big hospice providers and influencers, and has a lot of information to provide to us. And we're looking forward to live with us any moment here. Hey, doctor, are you there? There we go.
Hi.
Hey, good morning or good afternoon, and
Yeah,
thanks so much for being live with us today.
my pleasure. My imposter syndrome is raging following hospice nurse Penny, but happy to be here.
Oh, well, we are excited to be here, and I'm glad to say that there's less technical difficulties this time around. So I actually fixed my phone. It had a screen freeze last time, so I'm glad it's all working for us today. So, Dr. Tyler, why don't you give us a little debrief on your background and how you got into being a physician with that emphasizes on hospice and palliative care?
Sure. So my background, my medical training is internal medicine. So I went straight through internal medicine residency to palliative and hospice medicine fellowship, and I've been primarily an inpatient palliative care consultant since I got out of training some years ago now. And what that means is I primarily take care of folks who are in the hospital dealing with any number of serious illnesses like cancer or heart failure, lung disease. And we provide an extra layer of support to them. And that looks different depending on the person that I'm working with, but it can be working on symptom management like pain or shortness of breath or nausea, or it could be simply functioning as a sounding board to let them talk through what's important to them and measure that against the decisions that are in front of them and help them pick the right medical plan for who they are as a person and what's most important to them.
Great. I think for our audience who might not be as familiar with the role of a palliative care physician,
Yeah.
can you kind of explain a little bit more about how you work with all of the other clinicians that are in their cadre of uh, medical care?
Yeah. This is honestly the most common question that I field is what is palliative care? And I think I answer that question more often to clinicians than I do to patients. But very simply, palliative care is an extra layer of support for anyone dealing with a serious illness. There's no connection to prognosis or time or anything like that. It's simply for folks whose quality of life has been impacted by a serious illness, we're there to provide that support as I described. The way we interface with other clinicians, it honestly depends on your healthcare system and the model. For example, I work with folks who are referred to me by their primary clinician. And sometimes that's a general practitioner, sometimes it's an oncologist, or whoever they're the specialist managing the main illness impacting their quality of life. But they refer those patients to me, and then I work with them independently from there. But it is a lot of constant collaboration, especially for folks who I'm caring for in the hospital, where things are changing very quickly and there's a lot of stuff happening in parallel. And hospitals, oftentimes where communication can really break down across providers, and I'm there to kind of be that communication spackle to fill in the cracks and make sure that things aren't getting lost in communication either between providers or between provider and patient or between patient and family, family and provider, the whole milieu.
Great. You know, when people ask me what I know about palliative care, which is really a small amount, what I kind of portray it as, looking from a sales or marketing standpoint, is that's the account manager. It's their job to make sure that everyone's talking and everyone understands the game plan, and is the go-to person to talk to the client.
Yeah.
Would you agree with that kind of assessment?
Yeah, I do overall. I mean, we're very much person focused, and our specialty is kind of helping the patient stay feeling like the center of their care. And it's very easy to lose yourself and who you are as a person when an illness takes the forefront. And a lot of people are just trying to live normal lives, and they're constantly reminded that they're a patient, they're a patient, they're a patient, and they just want to be a person. So we try to bring the person back into that. And it admittedly is a very blurry line between where does palliative care begin and primary care end. And really, I think of it as there's no real need to choose. It's not a zero-sum game like who's quarterback, PCP versus palliative care, but we're really just trying to support each other. Because the reality is, for a general practitioner, they have very little time to be having these conversations. And most of the primary care docs I talk to want to have these conversations, but they either need a little bit of support to kind of have the coaching and the skills to jump into that conversation, or they just simply don't have the time, because the time demands on a primary care doctor are just out of control these days. And I think that's where a lot of the burnout's coming from, is that a lot of these other docs don't have the time to have these important conversations that they very much would if they were given the infrastructure to do so.
Right. I completely understand that. And, you know, it kind of taking along that track that physicians and clinicians want to have these conversations, but don't feel extremely comfortable with it. Yeah. It's interesting that your Instagram handle is How to Train Your Doctor. So talk to me about how you came up with that handle, or how that became your handle, and how can people talk to their physician or train their physician on what matters most to them? Yeah.
So that handle is a tip of the hat to the movie How to Train Your Dragon, with my little flavor of spiciness in there. And I mean, that really, it comes from this multiple times conversation I have with patients and families, where they're asking me, like, well, what do I say to my doctor to understand this? Or what do I say to my doctor to get my pain meds adjusted? Or what do I say to get more help at home? And it is a weird dynamic, because medical training, we're all technically speaking English, but it is like learning a foreign language. And we kind of get to the other end of medical training speaking this new language, and there's not a lot of emphasis on, well, how do we bring that back to the people we're taking care of? Like, how do we then retranslate that back to plain speak, and how do we say the things that we're really thinking in a way that strengthens the relationship rather than weakens it? And on the clinical side, I'm part of a nonprofit organization called Vital Talk, and they are dedicated to teaching clinicians, healthcare providers, how to have really hard conversations with people living with a serious illness. And we provide the structure and framework for all that, and really was an inspiration to me when I got to thinking, well, it would be really cool if we could provide similar training to patients and families to help them understand how to own the conversation rather than waiting for their doctor to take the lead. Because without the training, doctors often don't take the lead, and they're waiting for patients to bring up these big topics, because, well, a lot of docs have been burned trying to bring this up and it fracturing the relationship rather than strengthening it, and they're very reticent to jump back into that. And each patient's a new person with new values and new priorities, and only the patient knows what's important to them and what their priorities are. And my whole goal with this, whatever I'm doing on Instagram, is to empower people to really speak up and kind of jump into this conversation and make sure that everyone knows what their priorities are, so we can build the best plan around that.
Well, from a patient, and I don't like to use that term now that you had mentioned that people don't want to be patients, they want to be people. So, and I so agree with that, seeing as Five Wishes parent organization, Aging with Dignity, that's our mission, is to make sure that people, you know, their dignity is safeguarded. So I am right alongside you on making sure that people know that they are people first. And so what would be some conversation starters or some ways to bring up the conversation with your physician if you are, you know, let's say you're 65 and you're going in for your annual wellness visit. I know that physicians normally will have that conversation at that one marker, but if you're a relatively healthy person, but you want to talk about what is important because you never know if a serious accident might happen, how do you start that?
I want to take a step back and really acknowledge this part that you said, that there's a spectrum of relevancy when we're talking about the future and our wishes. And for some, it is still pretty hypothetical, and there's still a lot of life left to live and a lot of illness yet to declare itself that can really change how we're thinking about what's most important to us. And if we're talking to the person who wants to just start the conversation with their doctor, but there's nothing particularly wrong with them or a serious illness that we have kind of declared is going to be why they die at some point, I think it's great just to jump in any way you want to say, hey, I want to make sure that we're on the same page with what's most important to me right now. And I think the 5 Wishes document is a great way to start that conversation, to say, hey, I've been going through these, questions, and I want you to have a copy too, just for my records. And beyond that, I mean, of course, highlighting having a backup decision maker, I think is very important too. No matter who you are or how sick you are, things can happen very quickly. And I have a video about this too. You know, we don't drive around without car insurance. We don't plan on getting into a car accident in the same way we don't plan to get cancer or plan to get dementia. It happens to us, and it doesn't happen to us at a convenient time. It doesn't like book an hour in our schedule for, oh, is this an okay time to get cancer? Like, no, it happens. And I think the sooner you can just jump into the conversation, I think we focus too much on the actual choices or the actual questions, and really just showing your willingness to engage in talking about tough stuff, I think is so much more important than the content of the conversation, but more of the spirit of the conversation. To say, talking about this period is important to me, and I want to make sure that these topics stay in the dialogue moving forward. So I think whatever feels authentic to yourself and what's going on in your life in that moment is a great place to start. I think if you really just are totally fresh and otherwise healthy, going through your state's healthcare power of attorney documents and filling it out and giving it to your doctor to say, hey, I want to make sure you have this. And while we're on the topic, I want to make sure that you know that these things are important to me, and list out whatever those things are, whether that's family or fishing or fine dining, whatever it is, you know, start the conversation. And it's not a one and done thing. We don't have to end the conversation in the same day that we start it. But really just starting it is the most important thing.
Right. And, you know, I think also that physicians want to know about the people that they're serving and that they're caring for. They want to know more than what's in their chart and what's their lab results are. They want to know what is important to them. And a lot of times I believe patients feel like I get only so much amount of time with my doctor. There's so many medical questions I want to ask that the getting to know you on a personal level falls to the wayside. And I think that people really would, not only physicians and clinicians, but patients as well, have a better bond and a better understanding of their medical treatment and their whole medical journey if they spend just a couple more minutes getting to know each other, you know, getting to know your physician as a person, as well as the physician getting to know the patient.
And even that aspect of it is definitely something I think patients really need to own, to say, as we talk about my medical issues, you knowing me as a person is a medical issue that's important to me, even if it's not an issue per se, but making it clear that that needs to be part of your treatment plan, the knowing of who you are as a person and what's important to you. Folks really got to own it, whether you're living with a serious illness or not. As you said, physicians are more than open to doing this, but they never know who's in front of them, and they don't always know how to ask and put those feelers out to understand how much this person wants to know, what kind of information they want to get. And there's always plenty of conversation that they can have in a 10-minute visit that they don't necessarily feel the need to ask any given time. So if that's important that your doc knows who you are, you really got to just jump in and tell them that, hey, it's important that you know who I am as a person, and here's what I want you to know. And you're right, it only takes a couple minutes. And again, this is best done over multiple visits, over multiple years, if we have the luxury of doing that. And frankly, I think docs breathe a sigh of relief when a patient says, like, hey, like, I want you to know some things about me, and here's how I want to get information. It takes out a lot of guesswork. If something serious ever does happen, there's a lot of sort of hand-wringing that happens behind the scenes about, well, how much they want to know, how do I tell them, and I don't want them to feel this way or that way. If you just come out and say, hey, doc, I want you to know that I'm a straight shooter if anything ever happens, just tell me. They are breathing a sigh of relief, I promise.
Right, right. I agree. So, that's from a patient perspective on how to bring the conversation up to your physician.
Yeah.
From the physician standpoint, in a couple different scenarios, again, this is your annual wellness visit or you're a 40-year-old, pretty healthy adult. How do clinicians start that conversation, or what are some good pointers to start it? And then going into someone who actually has been diagnosed with a serious illness. And those are different conversations. So those two different scenarios, could you give some tidbits and pointers on how to start those conversations?
Yeah. Again, on the physician side, the clinician side, I would say you got to check yourself and ask, how worried am I about this person's health right now? And that will certainly guide how much time you spend, how deep you go in any particular visits. But if it's a generally healthy person, and I think you gave the example of a Medicare annual wellness exam, a great place to start is by just normalizing the conversation to say, hey, like there are some questions that I ask all my patients just so I get a sense of who they are and what's important to them. Weaving in who's your backup decision maker, I think that's a great place to do that, is just an annual wellness exam. There's also this dignity question that I'm going to get his name wrong, but it's Harvey Chachanov, who does a lot of work in dignity in Canada. He was just on the Jerry Pal podcast, which I have to put in a plug for Jerry Pal. But a very simple question that any doc can ask is, what else do I need to know about you to take the best possible care of you? And it's very open-ended, it's very quick to ask, and I think a lot of patients won't always know what to do with that question right away. But if you're planting that seed and showing that the answer is important to you just by asking it, it's something that you can come back to on subsequent visits to say, hey, I know I kind of caught you off guard with that question last time. I'm wondering if you had any chance to think about that, anything that you would add to that. And that is the awesome part about being a general practitioner and building these relationships over time, is that you don't have to do it all in one visit. You can plant a seed with a question that doesn't even have an answer and come back to that on a subsequent visit and kind of keep watering that, keep nurturing it. So if a serious illness does show its head, now you have a starting point. Now you have this general mutual understanding that there are some questions that we can start talking about in perhaps less hypothetical and more real. You say, hey, when we talked about what's important to you in the past, you said it was family and going to the baseball game. And, as we talk about treatment on the road ahead, there may be a time that we have to make some trade-offs here about how much you can get out of the house, for example, how much you can communicate. How are you thinking about what's important to you now? What's changed since then? And that what's changed question, I think, is a great one to jump back into. That we use a lot in folks who have started a conversation, but there's more going on and more to think about.
Mm-hmm. Great. So you had mentioned that one of the main questions that you always get is, what is palliative care? Yeah. What are some of the other questions that people ask?
Oh man, I spent so much time answering that one. We don't have time for a lot more. I think the other common question when I introduce myself is anything adjacent to the question of, are you the same thing as hospice care? And it is confusing because it's like we're board certified in hospice and palliative medicine. The words are right next to each other. So we're clearly related, and palliative care as a field is like super twitchy about being associated with hospice care because, honestly, there's a lot of gatekeeping with palliative care, and a lot of docs are reticent to refer to palliative care because they see it as active end-of-life care, the equivalent of comfort care, and something that you give to patients when the other things aren't working. And we have been trying very, very hard for close to 20 years now to make it clear that palliative care is support alongside the other treatments. And if all those other treatments aren't working anymore, then you talk to the hospice team. But if you're waiting for all the other treatments to not work and then getting palliative care, you've kind of waited too long to get the most benefit from it. So a lot of the other part I do is sort of related to what is palliative care, but also often fielding what is palliative care not, which is hospice care. We're very different than that. We're kind of further upstream, as we like to say. But inevitably, when I introduce myself to some folks, there's some clarification about what we're there to do and what we're not there to do. Oftentimes time comes up too, and there is at some point you got to acknowledge if we're involved, things are fairly serious. And often folks are relieved to see us because they see someone in front of them that will talk about the hard stuff. And one of the hardest questions that patients are often wondering if they don't ask it is, how much time do I have? And that's getting harder and harder to answer as medicine gets more and more complex. Yet we often know more as doctors than we let on. The classic cop-out is, well, I don't have a crystal ball, so I can't say for sure. And while that is true that we don't know the exact day, time to the second that someone's going to die, docs are pretty good with ranges of time, ranges being like, are we talking hours to days, days to weeks, weeks to months, months to a year or more? Docs are decent at that. At least they tend to be more accurate than people and patients are. And that's really what folks are looking for, is a ballpark so they can make decisions accordingly. Do I do the clinical trial? Do I do the surgery? Do I go on this vacation? Do I blow all my money going to Greece, or do I save and hit up Branson first and maybe Greece next year? So it's that probably be the most common clinical question that I get, is just people really, for the most part, want to know time. And again, on the doc side, we know as docs, not everyone does, and a lot of people aren't emotionally there. They're not emotionally ready to hear that. Some people never are. And because we're so afraid of giving too much information to a person who's not ready for it and just really doing harm, we just don't say anything. When my experience is, the most of the people do want this information. And so we sort of, I think docs need a lot of help with sussing out who's who and understanding who wants to know what. And that's often where we come in.
Right. And everyone approaches this completely different. That's what makes us individual people.
Yeah.
And I really enjoyed the point that you made that said that, bring this up little bits at a time.
Yeah.
Because, if someone's going to get a diagnosis, that's all they're going to hear for the most part. They're not going to hear anything else. So wait for the next time to bring up additional information or talk about advanced care planning at a different time, separate of the diagnosis.
Yeah.
Would you concur with that?
Absolutely, especially at the time of a new diagnosis. As you said, your hearing kind of goes out and everything is like the Charlie Brown adults at that point. And you do have to drip feed a lot of this stuff. And the most important thing you can do is keep the relationship going and keep the door open and say, look, we'll revisit some of this stuff as time goes on. What's going through your head right now? What questions spring to mind right now? And the reality is, most oftentimes it's going to be nothing, because it's just white noise at that point. But it's the asking and it's the follow-up, and it's the continuing to follow up and continue to keep the conversation going that is so important, because it's just, these are conversations that are the same as life and living, and what's important to us changes over time. And it's never something that you can hash out in one go. Well, at least I ought not to be.
Right. Well, that's a great way to end the conversation, that, these conversations are dynamic. They're not static. They need to happen throughout a person's life, starting, at 18 and going all the way through. And thank you, and the work that you do with the patients that you serve, as well as educating the Instagram community on what palliative care is and how it's so important in the medical landscape.
Thank you so much. I wanted to double check to see if there's any questions. I think I saw one come through. I think this was how to balance hope and optimism with reality. Do you have time to field some questions with me?
Yeah, let's do that.
Great. So this is a very tricky one, and I know Penny in her conversation with you referenced Sammy Winemaker and Xian Sao, who are the co-authors of this book coming out, Hope for the Best and Plan for the Rest. And the main key in all this is what they call walking two roads, and being able to live in the moment and take things a bit at a time, but also understand your trajectory and your arc, and being able to do both. And the reality is not everyone can do that. And again, why it's so important to start these conversations early and to normalize these conversations. Because if you've spent your whole life avoidant of hard things and get given a serious illness, no surprise you're going to cope by avoiding. We don't magically change personalities just because we were told we have cancer or dementia or heart failure. To this question of balancing hope and optimism with reality, I'll certainly ask people, what have you heard from the doctors? What questions are on your mind? What do you still want to know? And usually in how they answer that, I'll get a flavor for how they take in information and what they want to know. I will certainly ask them, like, do you want to know more? Are you someone that finds value in understanding your life expectancy? And to be clear, before I ask that question, I've talked to their referring doc, I've talked to their oncologist or cardiologist ahead of time to understand what they think, so they're not getting mixed messages. So I balance that too. And also a big part of what we do is trying to define hope and what are we hoping for. And most people, when they get a serious diagnosis, the initial hope is cure, remission, just getting this disease out of their life as quickly as possible so they can go back to how things were yesterday. But as that settles in and they understand that this is something that they're in with for the long haul, it's sort of revisiting that question: what are you hopeful for? What's most important to you today? What's going to be most important to you next month? And helping build, I forget who coined the phrase, but helping them build a hope portfolio. So as things change and one hope becomes less likely of a reality, we can shift to a different hope that they had, but keeping them in the driver's seat of naming those hopes. So they're always in control, but giving them the opportunity to pivot from one hope to the next. Hope versus optimism, I think, is an interesting question too, because I saw that we sort of put those with a slash between the two. Optimism's tricky. I think similarly, it's I think that's really more of a lens that we see the world through. I think people don't really shift from optimists to pessimists readily, or at least not typically. But it's certainly, you can ask that the other way, like, what are you optimistic about, and what are you looking forward to? And I think the second part of this is various points of treatment. And I do think, as we talk about the ongoing conversation, that begs the question, well, when do we revisit this? Is it every appointment? Is it every time we walk into the room in the hospital? Typically at time of diagnosis or at time of a hospitalization, kind of those are the typical medical events that we would revisit things. If we're switching from one treatment to the next, if prognosis is changing, we would revisit it then. Otherwise, probably, year to year for most people, depending on what you're dealing with. Yeah.
Great. That was a wonderful question, and and I think it goes beyond serious diagnosis. It goes beyond, it could be, you tore your ACL. What do you hope for, and how optimistic are you that you can get back to what you were doing prior?
Yeah.
So.
I mean, that's a great example, because a torn ACL would be a much different life event for me than a professional NFL player. For me, it would be very frustrating and annoying, but I could still do my job. I'd have like a tricked out scooter, but I could still do my job. And for someone in the NFL, like that can be a career-ending injury. And again, the piece that we haven't talked about that much in all this is really the identity of how we see ourselves and how an illness can challenge that. And it doesn't have to be cancer, right? A torn ACL challenges one's identity as a professional football player. If I can't play football, who am I? And we're all dealing with various challenges to our identity in conflicts big and small that we have every day. And an illness is just one example of that. But and I come back to that dignity question, what else do I need to know about you to take the best possible care of you? Sort of the beginning of making it clear that I care about you and your identity, and I don't want that to get lost in whatever it is we're doing here in this relationship.
Great. Well, again, thank you for your time and your patience. I'm sure are very lucky that they get to have the How to Train Your Doctor with them. So again, Dr. Tyler, thank you so much for your time, and thank you all for joining us today.
Thank you for building this platform to have these conversations. I really appreciate being here.
Great. We'll talk to you soon.
Bye.
Bye.